Hello and welcome to the Clinical Care Options Medical Specialties Podcast. I'm your host, Robin Black. Today's episode features a conversation between Dr. Joseph Kim from Q Synthesis LLC and Dr. Colten Bracken, who's on the board of directors from RHAU and UAFP, as well as owner and medical director at Main Street Family Medicine, PLLC. They join us today to discuss how to integrate comprehensive diabetes management to improve the quality of obesity care. You can take home lessons learned on how to deliver a similar project within your practice or institution. For more information on Drs. Kim and Bracken, along with a link to additional QI resources, please visit the show notes for this episode. Now let's get started and hear what the experts have to say about this important topic.
Today joining me is Dr. Bracken, who is going to be speaking to us about quality improvement in obesity as well as in diabetes. So thanks, Dr. Bracken, for joining us today. Let's start off by telling us about your practice.
Awesome. Well, thanks for having me. So my practice sits in a small town in southern Utah. We're designated as a rural health clinic. Our practice is a run-of-the-mill primary care practice. We do primary care visits from birth all the way to death. And it's in my hometown, actually. So I have a kind of a vested interest in taking care of my patients here, just because this is the little town that I grew up in. And it consists of myself, a physician, family medicine trained, and then I have two nurse practitioners that also work here in my clinic to help the workload. And we've been open since about 2021. And we started from scratch, built this thing from the ground up, including the building. And it's been just kind of a labor of love and a work in progress, that's for sure.
That's great to hear. So I know that you all have done some quality improvement work around diabetes and obesity. Tell us about that work, about the project, as well as we can start with some of the high levels of the results that you achieved, and then we'll dive deeper into some of the specific aspects of that work.
Yeah, so our project was a little bit unique in that we were starting literally from scratch. A lot of our patients were in the habit of coming in to see the doctor, and particularly from the diabetic standpoint, there's not a lot of great control of their diabetes in terms of their A1Cs were quite elevated, greater than 9%. And so we came into this community, we established this clinic, and really had to reinforce a lot of good habits and tactics to take care of their diabetes to try to get the results that we wanted. And so ultimately it was trying to look at our community and see, hey, there's some problems here in terms of not great care of diabetes, quite a high rate of obesity. What can we do as a clinic to increase those numbers? And that's really kind of the high level point of what we were trying to accomplish here.
I think it sounds like there was a real opportunity. You saw that need. So tell us about the ways that you determined, like, what were the goals and the aims of the project? Like, how did you establish that as you started that QI journey?
Yeah, that's a great question. I'd had a little bit of background in quality improvement through my medical school training. I had not really done a whole lot of specific projects on my own. And so this was a great opportunity to not only do it myself, but also to get my staff involved and to help them learn some of the tools of quality improvement. And so initially we got down to the basics and we did some things like a root cause analysis. We constructed fishbone diagrams to try to get at what are some of the kind of the low hanging fruit. What are some of the things that we can tackle right off the bat that's going to have a great impact on our patients' control of their diabetes. And one of the things we identified early on was that patients were just not coming back for their follow-up appointments. We would see somebody, for instance, and their A1C would be 10%. And we would say, okay, this is what we're going to do. We need to see you back in 3 months, if not sooner. And then we're going to recheck your A1C. And 6 to 9 months later, they'd show back up on our doorstep and still have a terrible A1C. We identified, gosh, we need to streamline the follow-up process, which was one of the big things that we used to tackle this. And we found that just by doing that alone, kind of putting a greater emphasis on this for our patients, that made a big change. That made a big difference.
In terms of tracking those follow-up visits, was that all built into your electronic record? Did you use different software like practice management software, or was there a different method altogether?
Yeah, so we kind of utilized a couple of different methods to ensure that follow-ups were happening. First of which was just in our EMR. So we use Athena, and it does have a functionality built in there to where we could order a follow-up visit, which would then generate system reminders. So the patient would get reminders. We would get reminders for that the patient is needing to be seen. So that was part of it, but we found that wasn't even quite enough in and of itself. And so we really utilized a care manager, which was a big part of this project and really took off. We'd kind of had a care manager before this, but she wasn't fully functioning. We didn't have a great direction. And so getting into this project really got her running with this and then other projects that we've subsequently done. But what we did is we had her start running reports every single month on the first of the month to say, okay, who are our patients with type 2 diabetes? Who has had an A1C that's been greater than 9%, and who is then due for follow-up visits? And then she made actual physical phone calls to the patients and said, hey, it looks like you're due for your appointment. Why don't you come on in? And we found that by her actually doing a warm phone call, people came in. Nobody ever said no to her when she called, which was great.
Yeah, it's that human touch. So it's so important. And that's great to hear. I think just having that person on the team and really empowering that person with that kind of a role. I think the other thing, one of the other things that you all also did was really increasing that documentation of obesity as a diagnosis. Can you tell us about that and sort of what led to that?
Yeah. Again, where we were starting from the ground up, we had no patient records. We really had carte blanche here as far as every single patient that came to see us, we had to establish and document all of their problem list, all of their health history. And so for the first few years of being open, it was quite daunting. Every single patient that came in, there was quite a bit of paperwork, quite a bit of just documentation. And we found that as good of a job as we were doing, a lot of things were falling through the cracks, particularly diagnosis of obesity. And you could say, gosh, why does that even matter? What does it matter if you actually put that on the problem list? And there's a quote that I like from Edward Deming, who's one of the fathers of quality improvement. He says, what gets measured gets improved. And so we found just by simply documenting the presence of obesity, BMI of greater than 30, and putting that in their chart, that brought up more conversations. We even had a few people of coming in and saying, hey, I saw that you said I was obese in my chart. What is that all about? And we had to explain to them, oh, this is a medical diagnosis. This is nothing offensive. But just by putting that in their chart and documenting it, it got addressed more often than it was before. We thought we had been doing a pretty good job of discussing weight management and counseling and whatnot. But until we actually started documenting every patient with a BMI of over 30 with obesity, we noticed we weren't doing as quite of a good job as we are doing now of addressing that.
So I know that often the treatment of obesity and diabetes, like sometimes it's the same treatment or the same medication that might address both of those. Did you find either synergistic effects of improving both obesity care and diabetes? Like, were you able to essentially come up with tactics to address both of those conditions at the same time?
Yeah, and they really need to be treated hand in hand, right? Like if you have a patient with obesity who also has type 2 diabetes and you're only focusing on diabetes, you're really missing out on half of their treatment. And they go hand in hand in terms of if you can help the obesity, it's going to directly impact the type 2 diabetes. And we all know this, but oftentimes we just get so ingrained in focusing on the A1C that we lose track of let's treat the whole patient as a whole. Perfect example of this, and I got her permission to share this, but my mother-in-law has type 2 diabetes. And we were able to get her off of a significant number of her diabetic medications because we were able to help her lose a substantial amount of weight during that same period of time. And so the direct correlation of helping her obesity then in turn worked on helping her diabetes control significantly. And so we found that by putting an emphasis on both of these in this project that we were doing, by documenting it and bringing it to the forefront of our conversations, the obesity, but also focusing on the care of their diabetes, we found that people noticed that and people could see, gosh, you guys are really putting a lot more emphasis on these issues. We can tell that this is important to you. And so consequently, it became important to them. And it just kind of built off of each other. So I think there's absolutely some synergy in addressing both of these problems together.
So tell us how you were able to get your staff involved in these QI efforts and how you either assigned certain tasks to them or gave them additional responsibilities as you went through this journey.
And that's a great question because that's a big part. Any kind of a QI project, you have to have your staff buy-in. Otherwise, there's only so much you can do by yourself. And Fortunate for us, I became kind of the champion of this project and really, really pushed it from the get-go. And as the owner of this small practice and as the medical director and the only physician, it was a lot easier. We didn't have to get buy-in from upper level management or any other parties involved just because I was the party involved. And so that made it a little bit easier on that regard. And from the get-go, we started holding regular staff meetings. We already held regular staff meetings, but specifically part of those staff meetings was dedicated to discussing our efforts, discussing our metrics, just kind of keeping it in the forefront of everybody's mind. And we published some of this information around our clinic so that we could see how we were doing. And then we assigned specific roles. Certain people were responsible for calling patients. It was ultimately my care manager's job to make sure that was getting done, but then she would assign that to some of our receptionists to do. We had standing orders in place so that if somebody came in for a sore throat, but we could see, hey, they hadn't had their A1C done in 3 months, that my medical assistants were empowered to automatically check an A1C and then bring it up in that visit. And so we kind of really got everybody from the receptionist to the medical assistants to my care managers to all of the providers involved from the get-go. And we talked about it regularly. And we found that getting everybody engaged, for one, it produced results. And then for two, it actually got them excited about it. They liked seeing the benefits that this was doing, that we could see actual tangible improvement in people's A1C and the documentation of their obesity in their charts. And so it kind of success begets success. And the more we were doing, the more excited the staff got about the project.
So far, we've been focusing heavily on the positive, which is great. Tell us about some of those challenges as well as how you were able to navigate around them.
Yeah, the hardest part, I think, is keeping it, keeping interest from everybody. Like I said, we had the regular meetings and we kept up on the metrics and we posted everything to try to keep it. But I read a book recently about the infinite game in terms of we're not trying to win or lose here. We're trying to continue to play this game and we're trying to continue to improve for the long run. This is not something that all of a sudden we fix their A1C and then we're done, right? We fix their A1C and then we still have to monitor that and manage that. So kind of setting that mindset that this is a continual process. There's not an end result here. And that's difficult with any human, just kind of creating that mindset. And then kind of some more nuts and bolts things. It was difficult with our EMR and we finally figured some of it out, but just getting the accurate data that we wanted took quite a bit of a learning curve to figure out, okay, where do we get the right reports and how do we get the right number of patients and how, so just kind of getting that raw data from our EMR took quite a bit of learning. Those are probably, I think, the two biggest things. I mean, there's always challenges in terms of like, we'll try an intervention and then find that, well, that wasn't very effective. And so we had to go back to the drawing board. And that's part of those PDSA cycles that they're supposed to be continuously ongoing towards that improvement. And the first one may not work very well. And that's okay. You learn from it. You study it and you assess it and you do something different the next time. But probably just kind of continuing that mindset of this is a never ending project. We never get finished with this, which is sometimes hard in our typical finite mindset, but we're getting there. I won't say that we're perfect at it and we're still learning. It's an ongoing process, but we are better than we were a year ago. I can tell you that.
Yeah, it's definitely that continuous journey, ongoing improvement. And you mentioned the care manager. I'd like to learn a little bit more about that person's role. Like, what is sort of that scope of responsibility at this time?
We had her on staff before. We kind of gave her this specific responsibility of being a chronic care manager, basically. And initially it was a little bit of a gamble just to designate somebody full-time, kind of away from clinical practice, if you will. They're not actually engaged with the patient on a day-to-day rooming patients. From a practice management standpoint, I worried that initially she wasn't going to generate revenue, right? That was she going to be profitable? And in hindsight, gosh, that making a full-time chronic care manager has been one of the best things I've done in my practice. So she initially was involved in this diabetes and obesity project and has been very, very influential. She continues to do that, but we've had her branch out and are now involved in chronic care management services, which just go hand in hand with this diabetes care and obesity care. And that involves her calling patients regularly, setting up appointments for them. She even does home visits sometimes and does vitals checks. And being in a small community, people love her and they trust her. And she's just an extension of me. And so it's been very beneficial to my patients. Being able to bill for the chronic care management, she's actually paying for herself. And so it's improving quality and it's improving care for my patients, without really costing my bottom line anything, which is fantastic. And then we've just recently been branching out into more remote patient monitoring, blood pressures, blood sugars, oxygen levels, those types of things, which again just provides us one extra tool in our toolbox to be able to really better take care of our particular Medicare population. They're aging and their health's only getting worse, and there's only so many primary care doctors out there. And so the more I use someone like April, who's my chronic care manager, the better I feel like I can manage our little population here. So she's just been very instrumental.
Yeah, it sounds like you've got a great team in place, and with all those roles and responsibilities clearly defined, you're providing better care for that community. Speaking of that community, what would you say are the biggest barriers to care for them? What do you find are really some of the big obstacles to them essentially coming and receiving care from your practice?
Yeah, we're in a very rural, primarily agricultural community. The community itself is maybe only about 2,000 people, but our catchment area is closer to 6,000 or 7,000 that kind of feed into the schools and the grocery stores and our clinic. And we find that, yeah, there's a certain amount of health literacy that people struggle with. There had not been really great medical care out here for a long time before we arrived. And so there's a lot of just misinformation out there, in the lack of good medical advice. People turn to the internet, and we all know, heaven knows what that people can find there. So that's been kind of a challenge to kind of educate people on proper ways to care for the diabetes and obesity and other issues. And access to specialists is another one. Let's say somebody needs to get in to see a cardiologist or go for an eye exam for the diabetes or whatnot. They have to travel at least an hour to get down to the closest city where there are specialists. And well, that's not a great distance. Sometimes that is a pretty big hardship for some of our patients who are on limited incomes or just don't have the means to make it down there and the time and whatnot. And so we are kind of in a resource limited area, which makes it challenging for our patients. Yeah, and those are probably the biggest ones that people struggle with around here, and they kind of make do. And a lot of times people have just kind of done without, unfortunately, for a long time. They just kind of, it's the old farmer mentality. If you just rub some dirt in it, it's going to get better. And unfortunately, that's what's happened for a long time. And it's getting better. And I'd like to think we're making a difference here. There's still a long ways to go there for a lot of people here.
The last question that I have is, what advice would you give to other rural sort of focused healthcare providers, rural clinics, people working in similar types of environments when it comes to improving obesity and diabetes care for their populations?
Yeah, I would say, just from my experience in this last year, really diving into this a lot more, is you really don't know what you don't know. And I thought we were doing a really good job. And I thought we were taking great care of our patients. And we were trying. But until we really started to dive into some of the measures and some of the numbers and really look at, gosh, maybe we could be doing better. And so sometimes just taking a step back and actually studying it and actually measuring things to say, gosh, yeah, we are very caring providers and we want what's best, but sometimes there's a better way, and learning from others. Part of this big project was, hearing from other clinics who were involved in the same type of quality improvement projects and learning their successes and their failures. And one of the big mantras that I learned in medical school from the Mayo Clinic is that no one's big enough to be independent of others, right? Like, medicine is a team sport. And so the best thing is just to learn as much as we can from others and to always try to be better, right? Like, we can always be better. As good as we are as providers, there's always room for improvement. So just get out there and do it. Get involved.
Thank you, Doctors Kim and Bracken, and many thanks to you, our listeners, for joining us. As a reminder, to view the additional QI obesity resources, please click the link in the show notes. And be sure to check back regularly for more episodes on important medical specialties topics.